Welcome to my YouTube channel. Today we're going to talk about unfractionated heparin. So, unfractionated heparin is under the class of heparins, and then above it, it's under the class of anticoagulants. So, let's first of all look at the classification of anticoagulants. So, what are anticoagulants? These are drugs that prevent formation of further clots. So, under the classification of anticoagulants, we have indirect thrombin inhibitors, and here is where we have the heparin. We have direct thrombin inhibitors, and then we have vitamin K antagonists. So under indirect thrombin inhibitors, as I said, here is where we have our heparins. And our heparins, we have unfractionated heparin, we have low molecular weight heparin, we have synthetic metasaccharides, and then we have the newly oral administered factor 10 inhibitors. So among the four of them, the first three are drugs that are given either IV or subcutaneous using a syringe, whereas the last, just from the name, it's an oral administered drug. So direct thrombin inhibitors, these are drugs that inhibit thrombin directly, whereas indirect thrombin inhibitors, they have to use antithrombin, they have to stimulate antithrombin 3, which later now inhibits factors such as factors such as factor 10A, and later now inhibit thrombin. So direct thrombin inhibitors include agobactran, then they include lepiridine, they include bivalirudin, and then dabigatran. So the first three of the drugs, these are IV medication, while the last is an oral medication. Then vitamin K antagonists include warfarin, which is an oral anticoagulant. So let's quickly look at the heparins. And under the heparins, we have low molecular weight heparins, and the examples include the parins. So anything that has parin, the low molecular weight heparin, that is enoxaparin, dalteparin, nadroparin, bemiparin, satroparin. And then the next thing is that the risk factors of heparins are less in low molecular weight heparin in comparison to unfractionated heparin. So it has a lesser risk of heparin-induced thrombocytopenia and osteoporosis. In addition to that, the reversal drug that we use or the antidote that we use in terms of low molecular weight heparin and unfractionated heparin, because just let me tell you, unfractionated heparin is a larger molecule, and then now from it we get low molecular weight heparin. So they share similar characteristics, but sometimes they do differ. So in terms of the reversal, on board we usually use protamine sulfate, but in terms of low molecular weight heparin, it has limited antagonism. And then we usually monitor low molecular weight heparin using anti-XA, whereas in unfractionated we usually use APTT. And then it is usually excreted through the kidney. So a patient who comes in, you want to give them anticoagulant, but their creatine clearance is less than 30 ml per minute, then you'll prefer using unfractionated heparin because it is excreted by the liver. So unfractionated heparin, it has an increased risk of HTI in addition to osteoporosis, and then it has an increased reversal by protamine sulfate, and then it is monitored using APTT and is excreted in the liver. So in synthetic heparinoids, this somehow the way synthetic and low molecular weight heparins, they are similar in terms of their mode of action, and the mode of action of low molecular weight heparin and synthetic heparin is they stimulate antithrombin 3, which later inhibits factor 10A. Whereas in unfractionated heparin, it still stimulates antithrombin 3, but now after stimulation of antithrombin 3, it inhibits both factor 2 and factor 10A. So an example of synthetic heparinoids include fontoparinax, selective antithrombin 3 inhibiting factor 10A, and it is excreted by the kidney. So a patient who comes in and has a kidney problem, which drug do you give? Unfractionated heparin. So let's dig it into the unfractionated heparin. So as we said, the mode of action of unfractionated heparin, it stimulates or enhances the activities of antithrombin 3, and then antithrombin 3 later inactivates factor 2 and factor 10A. Then after the inhibition of factor 10, in this pathway I went with the inhibition of factor 10A. After the inhibition of factor 10A, then we have reduced conversion of prothrombin to thrombin, and then later we have reduced conversion from fibrinogen to fibrin. So let's just look at what I said is in terms of secondary hemostasis, we have the extrinsic pathway and then we have the intrinsic pathway. Remember the intrinsic pathway. It's monitored using which factor, which value? It's monitored using APTT. So in terms of unfractionated heparin, it inhibits both factor 10A and it also inhibits factor 2A. So when it inhibits factor 10A, then we don't have conversion from prothrombin to thrombin. And also we don't have conversion from fibrinogen to fibrin. When it inhibits factor 2, then we also don't have conversion from fibrinogen to fibrin. And if you don't have conversion from fibrinogen to fibrin, then we don't have a clot formation. So I hope you have understood the mechanism of action of unfractionated heparin. So in addition to that, we also see the clearance is through the livers, and then it has a complete antidote or a complete reversal using protamine sulfate, and then it has a shorter half-life in comparison to low molecular weight heparin. So if you have a patient who has to go to surgery, for example, tomorrow or in the next few days, then you will prefer giving unfractionated heparin in comparison to low molecular weight heparin. In terms of administration, in terms of prophylaxis, you use subcutaneous. In terms of therapeutic infusions, in terms of therapeutic, you give IV infusions. What about low molecular weight heparin? Which mode of action, which administration do we use? Subcutaneous. So how do we monitor? We monitor using APTT. So in terms of the heparin uses, just to simplify, the heparin, how we use it is just to prevent formation of clots. So anything that will predispose us to formation of clots, then that's when we use heparin. What are the contraindications of heparin? Anything that, number one, will lead us to having side effects of heparin. Number one, which include bleeding. So anything that will lead us to having bleeding. Number two, anything that will lead us to having maybe in heparin-induced thrombocytopenia, or already maybe we have a reduced level of thrombocytes, and among other factors. So we're going to see. So uses in treatment of prevention of DVT. DVT is where we have formation of blood clots into the deep veins. In ischemic heart disease, this is when you have atherosclerotic plaque, which platelets play hemostasis play a role. Then we have rheumatic heart disease or atrial fibrillation. We have cerebrovascular or cerebral emboli. Remember our emboli, it's also in addition to prevention of recurrence. And then in vascular surgery, this is just for prophylaxis, and in prosthetic heart valves, hemodialysis to prevent thromboembolism. And then when you have DIC, placenta abruption in terms of malignancy, infection, and in a place where you have increased consumption of clotting factors. So contraindication about is hypersensitivity. Number two is when you have bleeding disorders such as hemophilias, where you have thrombocytopenia, as I mentioned before. One of the side effects of heparins is heparin-induced thrombocytopenia, and then where you have risk of having intracranial hemorrhage, and then where you have GI ulceration, because when you have an ulcer, you are more predisposed to bleeding. So if I give you heparin, then it's kind of I'm telling your GI, hi, I'm telling the ulcer, hi, then we can bleed because already I've given you blood thinners. And then when you have threatened abortions, then when you have renal or hepatic, advanced renal or hepatic disease. So the adverse effects we already talked about, and the first one is bleeding, the second one is heparin-induced thrombocytopenia, and we also have osteoporosis. So bleeding is the most common, and how do we stop it? We stop it by an infusion of protamine sulfate. The next one is allergy and anaphylaxis, which is heparin-induced thrombocytopenia, which is more common in which heparin? Unfractionated heparin. And then increased hair loss and alopecia, and long term when you use heparin greater than one, I think it's either 1 month or 3 months. I will confirm when I have a slide in terms of complications. Long term, that is osteoporosis and spontaneous fracture. So in terms of this, you consider low molecular weight heparin because it has a lower risk of us developing